Vicente Torres from the Mayo Clinic, and he's going to talk to us about practical guideline for treatment with V2R agonist in ADPKD. Welcome.
Okay, well, first I want to thank Dr. Pei for inviting me and being such a splendid host. He always is. And also Winnie Shank for being so patient and not pushing me too much to get the presentation sent to her. So these are my disclosures. And this is the outline of my talk. So I will talk about first the therapeutic potential of targeting cyclic AMP and vasopressin, the clinical trials of tolvaptan, a randomized clinical trial of hydration, and the adverse effects of tolvaptan, and finally when and how to use tolvaptan. So with the advances in the understanding of polycystic kidney disease, one can stratify the therapeutic targets, and of course the most effective therapeutic target will be to correct the gene defect or the polycystin expression and function. But the next level of therapeutic target is the basic pathogenic mechanism, which are, or we think that they are directly linked to the dysfunction of the polycystins. Sorry, that kind of advanced it. Okay. To the dysfunction of the polycystins, and cyclic AMP is close there. We believe at least that is closely linked. Other downstream signaling pathways may be complicated by counteracting effects, redundancies, and a lot of positive and negative feedback loops. And finally, there are all pathophysiological processes which are very important in polycystic kidney disease, but are non-specific and shared by many other kidney diseases. So this image you have seen several times already represents what the full therapeutic potential of targeting vasopressin is. Because if you eliminate vasopressin completely, in the Brattleboro PCK rats that have, the PCK rats have polycystic kidney disease, basically you will almost eliminate the disease. But these rats have huge amounts of polyuria. They urinate almost their body weight every day. And this, of course, is not feasible in humans. Now, to move in that direction, however, we have the vasopressin V2 receptor antagonist, the vaptans. The challenges with the vaptans is the low bioavailability and their short half-life. Because of the low bioavailability, the way they are administered usually in the clinic, in the preclinical studies, is mixed in the food at very high concentrations. And these concentrations have to be very high because you need to suppress the effect of vasopressin on the kidney continuously. And the rodents eat in the evening or during the night. So in the right upper panel, you can see that with a concentration of tolvaptan in the food of 0.06%, the animals, the rats in this case, are polyuric during the night, but then the urine output went down during the day. And this happens because the short half-life of the tolvaptan. And in the bottom, you have two different concentrations, with a concentration which is most commonly used, 0.01% in the food. You have very high levels early in the night or during the night, but they drop pretty fast in the morning. And if you reduce the dose a little bit, you have basically no tolvaptan in the blood. So because of that, you have to give a concentration that is high enough to suppress the vasopressin. Now, this problem also occurs in humans. So before starting the phase 3 studies, for 3 or 4 years, there were phase 1 and phase 2 studies that were run first to prove the safety of tolvaptan on short term in humans, and also to find the right dosing of tolvaptan. and to get some preliminary efficacy data. And what this graphic shows is the compromise that you have to reach between efficacy and tolerability when you administer tolvaptan. When in terms of efficacy was measured by the capacity to maintain the urine hypotonic related to the plasma continuously during 24 hours. And tolerability was measured by the self-reporting of the patient saying that they would be able to tolerate that dose for the rest of their life if tolvaptan would work. And you can see that it was necessary to use a split dose of tolvaptan in order to be able to suppress the effect of vasopressin on the kidney. But in addition to that, the dose have to, when you increase from 45-15 or 16 milligrams daily to 90 or to 120 milligrams, you didn't have much improvement in the efficacy, and you have a significant reduction in tolerability. And because of this, these doses were used to escalate the tolvaptan in the phase 3 clinical trials. So starting with 45-15, moving to 60-30, and then to 90-30. So the two major clinical trials of tolvaptan in polycystic kidney disease were the TEMPO 3-4 trial and the Reprise trial. The TEMPO 3-4 was in early ADPKD, and the Reprise was in advanced ADPKD. It was very important in the TEMPO 3-4 to use prognostic enrichment strategy, which indicated young patients, relatively young patients, age 18 to 50, with a total, but rapidly, with a still reasonable GFR with a creatinine clearance above 60, but rapidly progressive, defined by a total kidney volume of over 750 mLs. Now, the TEMPO 4-4 was an open label extension of TEMPO 3-4. Reprise was used a special design which randomized withdrawal rather than parallel arm trial in TEMPO 3-4, and I will go over the reasons for that later. And then on the open label extension of Reprise studied the effects of tolvaptan in very advanced ADPKD. So the primary endpoint in the TEMPO 3-4 was the increase in total kidney volume over a course of 3 years. And the results showed that the administration of tolvaptan resulted in a 49% reduction in the rate of increase in total kidney volume. But further analysis of the data showed that actually during the first year there was a reduction in the total kidney volume, which probably occurs very early in the first few months after initiating tolvaptan. And after the first year, the total kidney volume started to increase, although it increased at a slightly lower rate that increased in the placebo-treated patients. And the effect on total kidney volume was seen in all the groups, but was particularly seen was better in the patient that had already a creatinine clearance less than 60 mLs per minute. Now, the secondary endpoint was the time to multiple progression events, which included categorical change in hypertension, categorical change in albuminuria, episodes of kidney pain, and kidney function. And this also was a positive result, and that was driven mostly by the effects on kidney pain and kidney function. Now, on the kidney pain, on kidney function, the effect of tolvaptan started to be seen only in the second year of the trial, whereas the effect on kidney pain was started to be seen right away after the initiation of the trial. And the effect on kidney pain was mostly related to less stones, hematuria, and episodes of urinary tract infection. Now, this in a different study, not related to the TEMPO studies, the tolvaptan was shown to reduce the urinary lithogenic risk. And this was shown by a reduction in the supersaturation of urine for calcium oxalate, for calcium phosphate, and for uric acid, and an increase in the ratio of citrate to creatinine, and a reduction in the ratio of net acid excretion to creatinine. So it can improve the lithogenic profile, which probably results in the improvement of less risk for stone formation. And post-hoc analysis of TEMPO-3-4 also show improvement in blood pressure, which was seen mostly towards the end of the second year and third year, which may represent a reduction in the severity of the disease, and also a reduction in urine albumin excretion and a reduction in the excretion of MCP1. Now, the extension study, TEMPO-4-4, was done at the end of TEMPO-3-4. There was a benefit in the rate of decline of GFR of approximately 1 ml per year. And this benefit, and then at the end of TEMPO-3-4, the patient discontinued the administration of tolvaptan for periods of time that range between 1 month and over 2 years. Because of mostly the renewal of the contract with the different centers. And then in the extension study, and the tolvaptan administration was restarted. And when the tolvaptan administration was restarted, the difference in GFR that was gained by the end of TEMPO-3-4 was maintained during 2 additional years in TEMPO-4-4, indicating that the effect of tolvaptan on the decline of kidney function was sustained. Now, during TEMPO-3-4, there were about 23% of the patients discontinued the study, 1/3 of them because of aquaresis and others for other reasons. And that was of concern to the FDA. And the other concern was that the results of the TEMPO-3-4 were in patients with early ADPKD, so there was no certainty that the same would happen in patients with more advanced ADPKD. So the FDA requested that there was another study in patients with more advanced ADPKD and to use randomized withdrawal design in order to minimize the number of discontinuations during the trial. So in the randomized disorder withdrawal design, there is a running phase where both groups, the one randomized to tolvaptan and the one randomized to placebo, were treated with tolvaptan. So you can see that the GFR in both groups declined. Now, the patients that tolerated a dose of 60 milligrams in the morning and 30 milligrams in the evening were able to enter the study. And the patients that were randomized to placebo had a rebound of the GFR, shown in red, whereas the patients that were randomized to tolvaptan, the GFR stayed reduced. But during the 1 year of the double-blind period, the slope of decline of GFR was steeper in the patients taking placebo than in the patients taking tolvaptan. And when the administration of the investigative product was discontinued, the patients that were taking tolvaptan had a rebound. And this was the primary endpoint of the trial, was the difference, the change in GFR from the before taking tolvaptan to after the tolvaptan had been discontinued. And this was a difference of 1.27 mLs per year. Now, this was, so the reduction was greater in the placebo group than the tolvaptan group, with this 1.27 mLs per year benefit, but this benefit was not observed in the patients that were older than 55 years of age, were observed only in the patients that were younger than 55 years of age. The one reason for that could be that the patients that were older than 55 years of age who entered the study were a slow progressor. The rate of decline of kidney function was during the study was in the placebo-treated patients was lower than in the patients that were younger than 25 years of age. Now, at the end of the Reprise study, the patients entered an open label extension, and these in the patients that entered the open label extension that had a GFR that was very low, between 25 and 29, or between 15 and 24, were evaluated to see what happened when going from the Reprise trial to the open label extension trial to the patients who were taking during Reprise placebo and were taking tolvaptan. The patients that were taking placebo during the Reprise trial were dropping the GFR at a rate of 5.4 mL per year, and when they started taking tolvaptan, the rate of decline decreased to 3.4 mL per year. Patients that were taking tolvaptan during the Reprise trial, the rate of decline of GFR did not change between the Reprise period and the open label extension period. This is for the patient where the baseline GFR was between 15 and 24. For the patient that the baseline GFR was between 25 and 29, exactly the same thing happened. Patients who were taking placebo during the Reprise trial, when they shifted to the open label extension, the rate of GFR decline went down to minus 3.3. I will not use this information to kind of suggest that this should be a reason to start treating tolvaptan in patients with very low kidney function, but it is very helpful information when we have patients where the GFR is going down, and the question is frequently asked whether the tolvaptan should be discontinued or should be maintained. This data suggests that there is no reason to discontinue the tolvaptan in these patients. So to summarize these trials, the TEMPO 3-4 study show a 49% reduction in the rate of total kidney growth and a 26% reduction in the rate of GFR decline in early ADPKD, and had some other benefits. And the open label extension of TEMPO 3-4 showed that the benefit of tolvaptan obtained during TEMPO 3-4 persisted during the open label extension. The Reprise study showed a 35% reduction in the rate of GFR decline in advanced ADPKD, and the open label extension showed a 34% reduction in the rate of GFR decline, even in very advanced stages of ADPKD. Now, it's important to note the differences of the effect of tolvaptan by the CKD stage, both in TEMPO 3-4 and in Reprise. In TEMPO 3-4, there was no benefit, no significant benefit of tolvaptan in the patient with CKD1. And this is likely because these patients were doing well. The kidney function was not declining, and it's difficult to demonstrate a benefit when the kidney function was not declining. The largest benefit was seen in the patient with CKD stage 3, but both CKD stage 2 and CKD stage 3 benefited. In Reprise, the largest benefit was seen in the patient with CKD stage 3A, where the benefit was 2.36 mL per year, and the benefit was less in the patients with CKD 3B or CKD 4. Suggesting that maybe when the disease is more advanced, the benefit of tolvaptan may be less. Now, using the data from TEMPO 3-4 and from Reprise to extrapolate what the benefit would be long-term, both studies suggest that if you start treatment early in the disease, probably you can get extension of the life of the kidneys for about 6 to 7 years. And this benefit goes down the later when you start the treatment later in the course of the disease, and gets to be quite small when the treatment starts at a GFR below 30. Now, a question beyond the clinical trials is how tolvaptan would behave or would be in real life situations. In Australia, tolvaptan was approved in 2017, and at that time a program was initiated to monitor these patients, particularly with the interest of monitoring for the development of liver toxicity. And this program was called Imagine. And this slide shows the rate of the persistence of the rate of discontinuation of tolvaptan during these 2 years. And you can see that by age, the patient that have in the left panel, the patients that had the highest degree of discontinuation were younger patients and more than the older patients, which points to maybe a problem of trying to identify the causes of why younger patients are tolerating the medication less well. And the time to discontinuation for any reason was usually mostly in the first 10 months of treatment, but particularly in the younger patients, particularly those that were due to aquaretic adverse events occur in the first few months, in most of them. So again, younger patients and mostly in the first few months because of aquaretic events are the scenario where discontinuation of the drug occurs more frequently. It's interesting that in this study, or this the discontinuation due to abnormalities of liver function test was only in 2.1% of the patients, so kind of a very small percentage of patients. Now, there are 4 studies that have a look at the long-term, not long-term, but longer-term outcomes. And 2 studies, one from Mayo and the Otsuka pooled data study, were comparisons between patients taking tolvaptan and historical controls, either from CRISP or HOLT, or from other studies with the standard level of care. And the other 2 studies that were kind of registered in the clinicaltrials.gov were from Japan, and one of them, and both of them compared the rate of decline of kidney function before and after starting tolvaptan. One thing that can be seen in that is these 4 studies, there was a benefit of the administration of tolvaptan, which was in most of the studies approximately 1 or slightly above 1 ml per year. And in the 2 Japanese studies, it also showed a benefit on the rate of increase in total kidney volume. So this is the best information we have in terms of long-term, although recognizing that is relatively long-term, not very long-term. Now, there is a clinical trial which is ongoing in pediatric patients that is in Europe. And this is a 3-year clinical study, which I think has been completed, but the results have not yet been published. The only published results are the 1-year interim results that they were presented at the ASN Kidney Week in 2021. And this study is performed in children from 4 to 17 years of age that had relatively preserved kidney function with an eGFR above 60 mL per minute at entry into the study. And the goal of reducing urine osmolality at 1 year was achieved. The change in total kidney volume moved in the right direction. It went down to 2.3% rather than 6.1%. And also the change in eGFR went in the right direction. It went down from 2.7 mL per year compared to 3.2 mL per year. But neither one of these changes reached statistical significance, possibly because of the heterogeneity of the patients and the short follow-up, only 1 year of follow-up. But there were no severe adverse events. There were 2 discontinuations, one in the tolvaptan group, one in the placebo group. So these results certainly are not conclusive in any way, but they suggest a possible benefit which requires further investigation. So I think the results of the 3-year trial, when they are published, will be quite informative. Now, another study from Australia compare the effect of prescribed hydration versus water at lip. And the study was successful in reducing the urine osmolality by approximately 100 milliosmoles in the 24-hour urine. and also successful in increasing the urine output by approximately 400 mLs per day in the study. However, the study was not successful in reaching the desired adherence to the treatment, to the prescribed water, because this was measured by the capacity to maintain a 24-hour urine osmolality below 300 milliosmoles per kilogram over 50% of the time points where it was measured. And this occurred in only about half of the patients who were prescribed enhanced water, but also occurred in about 17% of the patients who were on the control group. So there was such a degree of overlap that the results of this study in terms of the effects of drinking water should be or are inconclusive. In addition, the study was aiming to reduce the release of vasopressin, and this was measured by the levels of copeptin, and there was no difference between the copeptin levels in the control group and the enhanced water group. So again, this study was negative because there was no difference in the rate of increase in total kidney volume, and there was no difference in the rate of decline of kidney function. But I don't think this can be accepted as conclusive against the value of enhanced hydration. Now, the main, well, it's not a side effect because it's an expected effect of tolvaptan is aquaresis. So it has been an issue in terms of discontinuation of the treatment, particularly in young patients. So there are different ways that one tries to reduce this aquaresis. One of the ways is to enforce or to kind of encourage the reduction in salt intake and moderate protein restriction, because by reducing the osmolar load, you may be able to reduce the amount of water that you need to drink to excrete this osmolar load in the urine. So that's one thing that is recommended to patients taking tolvaptan. Another possibility is to use therapies that may reduce the effect of tolvaptan on aquaresis. And one thing is hydrochlorothiazide that has been used for the treatment of nephrogenic diabetes insipidus. And this is a study from the group in the Netherlands and from Groningen that used hydrochlorothiazide, and with hydrochlorothiazide, and also they try also metformin. Both were effective in reducing the polyuria in patients with polycystic kidney disease. In hydrochlorothiazide went down from 6.9 to 5.1 liters, with metformin from 6.9 to 5.4 liters. With placebo also went down, but not as much. And so this looks quite promising. However, looking at the changes in renal function with hydrochlorothiazide, the GFR went down from 55 to 51. That's not necessarily surprising, and as long as it doesn't keep going down faster, it's not an issue. With metformin, the GFR did not change, and with placebo, did not change. There's a similar study. That's the study also in the group from Groningen has done a study in an animal model of polycystic kidney disease, and also shown that the animals taking tolvaptan and hydrochlorothiazide, there was a significant reduction in the urine volume, and there was no adverse effect in terms of the severity of the cystic disease. The animals taking tolvaptan and hydrochlorothiazide in terms of total kidney volume, kidney body weight, cyst volume, and cystic index were not different from the animals taking tolvaptan alone. So it did not interfere with the benefit of tolvaptan in the animal model. And the one thing, however, hydrochlorothiazide alone appeared to be aggravate, although not statistically significant, but the parameters are going in the wrong direction with hydrochlorothiazide alone, which I think is interesting. But in combination with tolvaptan, there was no detected adverse effect there. So that's, again, that will be supporting of this study, and there is a large study that is going to start very soon in the Netherlands, which is called HydroProtect, which is a study, will be a randomized study in 300 patients to determine whether hydrochlorothiazide can be used safely and effectively, and maybe increase the effect of tolvaptan in patients with ADPKD. Now, there was a similar study in Japan using trichloromethylthiazide, which is another thiazide, and also shown the same effect, because in Japan they use lower doses of tolvaptan. The decrease in urine output from 4.3 to 3.3 is about the same, but the baseline urine output is lower in this particular study. Now, in terms of hepatotoxicity, that was a surprise in the clinical trials of tolvaptan, because it had not been noted in other clinical trials for other conditions with polyuria. But when liver enzymes go up, especially transaminases, 3 times over the upper limits of normal, that indicates the risk of drug-induced liver injury. And this is a recent paper, just was published in American Journal of Kidney Diseases, which updates the experience with tolvaptan and hepatotoxicity in all the clinical trials from Otsuka and the open label studies and clinical continuations. And it involves experience in over 2,900 patients, 2,300 of which had been exposed to tolvaptan for more than 18 months and 800 for more than 5 years. So in TEMPO 3.4 and Reprise, the elevation of transaminases over 3 times the upper limit of normal were 4.4 and 5.6% compared to 1% and 1.2% in the placebo-treated patients. There were 2 patients in TEMPO 3.4 and 1 patient in TEMPO 4.4 with met highest law. Highest law means that in addition to the elevation of transaminases 3 times above the upper limit of normal, there is an elevation of bilirubin 2 times above above the upper limit of normal. And when that happens, there is a 10% risk of irreversible liver failure. So it's a very serious adverse event. These 3 patients recovered the liver function, so they did not go into liver failure, but still that was a major concern. And because of this major concern, the Food and Drug Administration, when approved the use of tolvaptan, had a REMS program requiring that after initiation of tolvaptan, liver function tests are measured at 15 days or 2 weeks, at 1 month, monthly for the following 18 months, and then every 3 months. Now, with this, after the implementation of this, there have been no further cases of Hy's law, which suggests that the mitigation program seems to be working. Now, the elevation of liver enzymes in tolvaptan, when tolvaptan is administered, has a very characteristic clinical signature, which says that these elevations occur usually in the first 18 months of treatment, not later on. That the liver enzymes can continue to increase after the discontinuation of tolvaptan for a number of weeks, and that it may take several months for the liver functions to return to normal after discontinuation of tolvaptan. So the hepatotoxicity of tolvaptan is thought to be due to an oxybutyric acid metabolite of tolvaptan. This metabolite has a very long half-life, over 180 hours, which may explain why the liver enzymes continue to increase for several weeks after discontinuation of tolvaptan. Have a high lipophilicity, which is a characteristic of drugs that have been associated with drug-induced liver injury. Is a strong inhibitor of the bile salt excretory pump, which results in accumulation of bile salts in the hepatocytes, and is a strong inhibitor of the mitochondrial respiratory chain, which may account maybe for the hepatotoxicity, and has been suggested that may account also for another side effect, which is elevation of creatine kinase. Questions are still not completely resolved is whether the tolvaptan dose is important. Now, patients that have a GFR below 30 have a greater exposure to the tolvaptan, whether that plays a role. in the hepatotoxicity is another unresolved problem, and the role of adaptive immune response also has not been clarified. Now, another adverse event that has been reported more recently is the elevation of creatine kinase. This study was triggered by the report of 2 patients that developed elevations of creatine kinase, with one of them at least with myalgias. And because of that, the study from Barcelona in Spain showed, surprisingly, that a high percentage, almost 30% of the patients starting in this particular study, starting on tolvaptan, had an elevation of creatine kinase. However, only 3 of these patients, 2 of the patients because of myalgias, and 1 patient because of continued elevation had to be discontinued because of that. And the remaining patients were able to continue taking the tolvaptan, although in a few of them the dose of tolvaptan was reduced or stopped for a short period of time. So that's something that will require further monitoring and is worth to keep in mind. And maybe something that could be suspected in patients that have elevations of AST and not of ALT. And since we do the monitoring for the liver enzyme, that might be a clue. And then another adverse event that has been suggested, or has been the warning has been raised in the concern has been raised in the literature, is the possibility of increased thromboembolic events. This again was triggered by a case report, and the investigators looked at the files from the Food and Drug Administration adverse event reporting system and found a number of thromboembolic events. And the ones that may be concerning are the ones associated with deep vein thrombophlebitis or pulmonary embolus and portal vein thrombosis. The other ones, I think they occur quite frequently in patients with CKD. I don't think this report really shows in any way that there is an association between the administration of tolvaptan and these events, because you would expect these events not to be that rare in the CKD population, but something maybe to keep in mind. Factors that contribute to thrombotic events in ADPKD include the chronic kidney disease itself. In ADPKD could be erythrocytosis, IVC compression, and hepatic venous outflow obstruction. So maybe in patients that have severe IVC compression or have erythrocytosis, maybe it's good to keep that in the back of the mind. So the tolvaptan has been approved in many countries, and in most countries it has been approved in patients with rapidly progressive disease. The question is how to define rapidly progressive disease, and you have already heard a lot about that. Today, the biomarkers that have been approved by the FDA and the EMA are GFR and total kidney volume, along with the age of the patient. And what the Mayo image classification has done is to integrate these 3 in a single simple classification that makes it more practical and easy to use. And this is to be implemented mostly in patients that are 55 years of age or younger, patients that have a GFR over 25. And that doesn't mean that tolvaptan cannot be considered in patients that are older than 55, or even in patients that have a GFR of 25 or less, but one has to be more careful, and they're kind of is particularly important informing the patient, discussing with the patient, and having the feedback from the patient before deciding about what to do. Now, the other way to do the prognostication, defining rapidly progressive disease, is the revised European classification, which is based on eGFR below age-specific cutoffs plus a rate of GFR decline of more than 3 mL per minute per year. Although they also admit Mayo image classification 1D or 1E and possibly 1C. So this is more difficult to apply because very few patients have information to determine for sure the rate of decline of GFR and other reasons. And then you already heard about the genetic testing that is useful for populations, but is not really very reliable at individual level. So with all these methods still, I think at the present time, the Mayo image classification seems to be the most practical and reliable. So we learn a lot. The different investigators in the Otsuka trials learn a lot about how to manage patients with polycystic kidney disease with tolvaptan. And because of that, when the tolvaptan was approved, there was some work together to kind of reach a consensus about what should be done, how should be implemented the treatment in the clinical setting. And this involves a number of steps that are listed here, starting with confirming the diagnosis of ADPKD, which most of the times is straightforward, but not always, and also confirming the diagnosis of rapidly progressive disease. And beyond that, once you confirm the diagnosis of ADPKD, rapidly progressive disease, and you have seen that before, then if the patients are Mayo image class 1C, D, or E, one can consider starting treatment. But in all cases, whether they meet the criteria or not is very important, as you already heard from Dr. Perron, to optimize the ADPKD management. Now, it's very important to educate the patients before starting treatment with tolvaptan. And this education includes about the polyuria and nocturia. And I think it's the communication with the patient may minimize a lot the discontinuation of treatment in the early months of the disease if you kind of inform the patients properly and do adjustments that we can discuss a little bit later properly. Now, they should be informed that tolvaptan enhances tubular glomerular feedback, and because of that, we expect a reduction in GFR of 5 to 10%. And this is more noticeable in patients with early disease than in patients with advanced disease. There is a study suggesting that actually the patients that have the higher degrees of decline of reduction in GFR acutely after initiation of tolvaptan are the patients that have best long-term results of treatment with tolvaptan, but that comes only from one study, so needs to be confirmed by other studies. And then also it is important because of the to inform the patient that increase in serum uric acid is something that is quite that we can expect, but this increase in uric acid is usually not very great. There is an increased frequency of gout, but again, is only in relatively small number of patients, and they may need to adjust antihypertensive therapy, especially long term. So it's very important to kind of prevent the immediate effect of aquaresis. So it's important to start on a Saturday or Sunday on a rest day, not to start on a work day. That makes it miserable. To drink enough water, patients should be to learn to drink enough water to prevent thirst. To avoid fluids with high sugar or fat content. To drink at least 2 to 3 liters during the daytime, plus 1 or 2 cups at bedtime and at night if they have nocturia. And that's minimum, as most patients may need to drink more than that. And dietary changes to reduce daily osmolar loads, so low sodium diet and moderate restriction in protein intake. Monitor body weights, especially in the early treatment, in the early phases of treatment. And then it's very important to hold tolvaptan in conditions that interfere with hydration or leading to dehydration, and to ensure water quality. So in terms of starting tolvaptan, usually we start tolvaptan at the dose that was started in the clinical trials, 45-15. And we try to increase the dose to the maximally tolerated, so 90-30, like it were done in the trial if it was possible. It is unclear whether that's necessary or not, whether it may be possible that a target should be just keeping the urine osmolality before the morning dose below 280. But this has not been proven since this was not done in the clinical trials. So we kind of have a flexible disposition about that, depending on how much the patient complains about aquaresis. In some patients that have problems with aquaresis, this in the clinical condition, there is no reason why not to start the tolvaptan at a lower dose of 15 milligrams twice daily, and then to increase it more slowly, because that may keep patients taking the tolvaptan that otherwise would discontinue. And then the other part is to monitoring. And this monitoring is not only a liver function test, but also we monitor for hydration. At the time when we measure the liver enzymes, we measure also plasma sodium, because we try to maintain it within between 135 and 143, something like that. If the plasma sodium goes too high, it means that they don't drink sufficient, or that maybe take too much tolvaptan. If the surprisingly, some of these patients have hyponatremia, which may mean that they overdo it with water. So that helps to correct both things. And then we tolerate acute decline in GFRs when starting of up to 10%. But if it goes up to about 20%, then that's a little bit worrisome. And in those cases, we reduce the dose of tolvaptan, or we may even hold it for a few days and restart at a low dose. And then finally, well, in terms of liver function tests, if there is an elevation of liver function test, which is over liver enzymes over 3 times the upper limit of normal, and there is no reason, no explanation for that, we believe it's better not to restart tolvaptan, especially if it's 5 times above the upper limits of normal. And if it is only 3 times or slightly less than that, one could consider rechallenging with a lot of care and frequent monitoring, but might not be worth the risk. And also patients that have risk symptoms of liver injury, of course, they should not be restarted, but this will not happen in isolation. It will happen also with liver enzymes elevation, so that would be pretty obvious. And then final thing is how to monitor whether the tolvaptan treatment is successful or not. Patients want to know about that. There are 3 things that one can do. One is one measure the rate of decline of kidney function and see whether declining at the expected rate corresponding to the image classification or not. Sometimes one can plot the rate of decline after a few years and to see whether there is a shift from one class to the lower class or a tendency to go that way. That would be, there's one possibility. Measuring the kidney volume, we do not recommend that, although maybe after 3, 4, 5 years, one can do that and again do the same calculation. And then quality of life is important. And I think that's the thing, and here go 2 questions. So the first question is, which of the following is most helpful to the nephrologist in deciding whether to recommend treatment with tolvaptan to a patient with ADPKD? Reported kidney length by ultrasound, reported measurement of total kidney volume, direct examination of an abdominal MRI by the nephrologist, results of genetic testing, and estimated GFR. We have enough answers, or? Oh, this I added just today, so you may not have that. Okay, so okay. Well, so the answer here is direct examination of the abdominal MRI by the nephrologist, because the length by ultrasound is not reliable enough. Reported measurement of total kidney volume does not exclude any atypical disease. Results of genetic testing, again, are good for populations, but not good for individuals. And estimated GFR by itself is not good enough. So that's be the answer. And the next question is, in the countries where vasopressin V2 receptor antagonist has been approved for the treatment of ADPKD, which one of the following patients is likely to derive the most benefit from treatment with the drug? 55-year-old man with a height-adjusted total kidney volume of 300 mLs, 35-year-old woman with a PKD2 mutation and serum creatinine of 0.9 milligrams, 30-year-old man with a height-adjusted total kidney volume of 1,200 mLs and a serum creatinine of 0.9 milligrams per deciliter, 70-year-old man with a serum creatinine of 2.6 milligrams per deciliter, and a 40-year-old woman with a total kidney volume of 1,803 cysts, accounting for most of the volume, measuring 520, 464, and 285 mLs. So, they give you the answer.
Do you want to ask people who is going to raise a hand for A?
B?
B?
C?
C?
Okay, all 100%. Okay, well, and the last slide is thanks or acknowledgments to Jerry Grantham, who focused research for PKD on cyclic AMP, and Vince Gatton, who was a pioneer in focusing on vasopressin, the NIH, NIDDK, and the PKD Foundation that supported many of the studies that make or help in the implementation of the clinical trial, providing the underlying knowledge that was necessary to design a proper clinical trial for PKD. The Mayo Translational PKD Center also, because of the contributions to the same thing. Otsuka Pharmaceutical for funding the trials. And then the Tempo and the Reprise investigators and the committee members, particularly the steering committee. And then the ADPKD patients participate in the clinical trials. Thank you.